Good evening, students. Good evening, everyone. I hope the audio and visual are fine. Please let me know if you can hear me. So that we can start with the session. So I welcome you all to the MDS 360 degrees session for oral and maxillofacial surgery. In today's session, we will be essentially discussing questions related to TMJ. All right. TMJ and its disorders. And in the end, I have one question from condylar fractures, which I'll be using to explain the difference between displacement, deviation, and dislocation. Okay, so let's start this session, all of you, and let's make it interactive. I want all of you to answer in the live chat box. Please answer along with the question number so I'm aware what question you have answered. Also, please don't be afraid to answer even if you are not confident or even if you are not thinking on the correct lines, because this is your best way to practice and correct yourself and retain things better for the long term up till your exam. So I'll read out the question and your options. Let me know the answers in the chat box, followed by which I will explain how we reached the correct answer. So starting with question number 1, which of the following statement about the temporomandibular joint is false? A, it is a synovial joint. B, it is a gangliomo-arthroidal joint. C, it allows for translational gliding movement. D, posterior TMJ dislocations are more common than anterior dislocations. So what would be the answer here? So all of you who have joined in live, please answer so that you can get confident and you can eliminate your mistakes if you're making any. Okay, I have got one answer. Any more answers? So let's see, it is a synovial joint. Yes, this is correct. It is a synovial joint. It is a gangliomo-arthroidal joint. This is also correct. Okay, and it allows for translational or gliding movements. This is also correct. Option D, posterior TMJ dislocation are more common than anterior dislocations. This is the correct answer. Please remember to read your question carefully. The question is asking to pick out the false statement or the statement which is not correct from your given options. So option D, posterior TMJ dislocations are more common than anterior dislocations. No, anterior dislocations are more common than posterior dislocations. anterior dislocations are most common. Okay. Let's move on to this second question. Following are the normal features in temporomandibular joint except A. Joint sound, B. Pain while opening the mouth, C. Deviation on mouth opening, D. None of the above. What would be the correct answer here? What would be the correct answer? Also, please mention the question number while you're answering in the live chat box so that I'm aware what question you have answered. Any answers here? Okay. Now, let us understand this question. Okay. It is asking you which are not normal features. All right. Which are not normal features. So, let's see one by one. Joint sound. Okay. Now, please remember, joint sound can be seen associated with the pathology also. Okay. And joint sound can be present without any underlying pathology also. Why? I'll tell you. Just wait. Similarly, deviation can be associated with a pathology or underlying disease process or underlying issue, and deviation can also be seen in a normal TMJ. Now, why do I say joint sound and deviation can be seen in a normal TMJ? It is usually seen in people with unilateral chewing habits. All right. So what is happening in patients who are predominantly using one joint over the other for chewing? All right. So that particular joint, let's say, suppose a patient is using only or predominantly chews from the right side. All right. So what is happening? The right TMJ is getting loaded more in comparison to the left TMJ. All right. So the right TMJ may undergo some wear and tear, but it has still not gone into some derangement process, or it has not gone into some underlying issue. It is a normal joint, but due to it facing more than normal functional loading, it may develop joint sounds or it may develop deviation. All right. So joint sounds and deviation can be seen in a normal individual as well. All right. Whereas pain definitely signifies that there is a underlying issue which needs to be addressed or which needs to be taken care of. You will never find pain in a normal temporomandibular joint. Okay. Pain will always be associated with some issue which you have to investigate and find out. But joint sound and deviation can as well be present in a normal TMJ. So, pain while mouth opening or pain on chewing, anything, or just pain can never be present in a normal joint. It can never be a normal feature of a TMJ. Is it understood to everyone? I hope it is clear. Harkirat, Aarti, the question is clear to all of you now. We'll come on to the next question, that is question number 3. Least preferred method for treatment of unilateral TMJ ankylosis is A. Temporal fascia, B. Condyle shave, C. Contralateral condylectomy, and D. Ipsilateral condylectomy. What would be the correct answer here? Anyone wishing to answer this question? Okay, let's see our options one by one. So, temporal fascia. This is used as a glenoid fossa lining material. Alright, to replace the disc. Fine. Okay, I have one answer. Now, if you see the rest of the options, condyle shave, contralateral condylectomy, ipsilateral condylectomy. Good evening, HS. Thank you for joining in. So if we now look at the other 3 options, okay, they are all wrong. But amongst these 3, we have to still pick out the option which is not at all used in the treatment. Okay, we have to pick out the option which is not at all used in the treatment. Okay, condylar shave is not usually recommended for ankylosis, but it can be used for very mild fibrous ankylosis. Alright, it can be used for mild fibrous ankylosis, although it is not recommended, but it can be used for mild fibrous ankylosis. Okay, and yes, ipsilateral condylectomy followed by arthroplasty. Yes, this is used. Ipsilateral condylectomy, rather than writing it this way, so I'll write that it is ipsilateral condylectomy plus resection of ankylotic mass plus arthroplasty. Okay, so this can also be used. It is a part. Alone condylectomy does not make any sense. Okay, so the best answer here is contralateral condylectomy. Please remember, students, you can do a contralateral coronoidectomy, but you will never do a contralateral condylectomy. You will never remove the opposite side condyle. Okay, that is not indicated. It is not a part of treatment protocol. Further ahead in our sessions, we will be discussing Caban's protocols. We will revise the Caban's protocols and we will see what all we can do for the treatment of a TMJ ankylosis. But contralateral condyle, the opposite side condyle, you never remove for treatment of a unilateral TMJ ankylosis case. You can do a contralateral coronoidectomy. Okay, so I hope this is clear to all of you. Fine. And also I want to tell you one point. Please remember, whenever the question asks you regarding the treatment for TMJ ankylosis, you will always mark interpositional arthroplasty followed by gap arthroplasty, followed by condylectomy. You will answer in this particular order. This is how you're going to answer. Okay, this is important. Please take note of this sequence. Now let's come on to the next question. An 18-year-old female patient presents with tenderness and spasm of her masticatory muscles and difficulty and limitation in mouth opening. MRI scans of her temporomandibular joint are unremarkable. What would be your most likely diagnosis? So please let me know the answer to this question. So please answer. Any one of you wants to answer? Okay. So I have a few answers. Let's see. Let's read the question and let's pick out what information is being provided. 18-year-old female patient presents with tenderness and spasm of her masticatory muscles. Okay. Difficulty and limitation in opening her mouth. That is, mouth opening is restricted and it is difficult also and it is painful also. Okay. MRI scans of her temporomandibular joints are unremarkable. That means MRI is normal. What would be the most likely diagnosis? Okay. So it is definitely not temporomandibular joint because they will have some radiographic findings. It is definitely not arthritis because there also there will be some radiographic findings. It is also not derangement of temporomandibular joint because in that case the disc would be not present in a normal relation to the condyle or the glenoid fossa. The disc would be displaced. Alright, so the answer here is myofascial pain. Because in myofascial pain, the radiography of the joint is normal. There is no abnormality radiographically. There are just clinical signs and symptoms which are present and on the basis of which you diagnose the patient. Okay, so let's go ahead. HS, I hope you have understood the question and the answer. Coming to question number 5. A 35-year-old female banker presents with pain and clicking in her temporomandibular joints bilaterally. She also has a history of bruxism. You make a provisional diagnosis of an internal derangement of her temporomandibular joints. Which one of the following may be the least appropriate measure to manage her condition? A. Prescription of analgesics. B. Provision of night guard. C. Recommend chewing gum. D. Advise soft diet. So what would be the answer here? Very good, HS. Okay, I have one answer. Any more answers? Okay, very good. All of you have got this answer correct. So, what you will not recommend is chewing gum. Okay, the patient is in pain. Okay, she has a history of bruxism, and you have made a provisional diagnosis of internal derangement. Okay, and there is clicking also, pain, clicking bilaterally. So in such a condition, rather than causing exaggeration of the condition, you will try to get the condition to subside. So you will advise rest. Alright, you will treat the patient symptomatically. You will give a analgesic for the pain. You will give her a night guard for the bruxism problem. And you will give her soft diet so that the functional load on the TMJ is minimized. Whereas your chewing gum is going to increase the functional load on the TMJ by a large amount. So you will not recommend chewing gum. Let's come on to the next question. Caban's protocols are applied for A. Management of Leaford tree fractures, B. Management of blowout fractures, C. Management of TMJ ankylosis, and D. Management of chronic dislocation of TMJ. So this question here is to revise Caban's protocols. So once you tell me the correct answer, we'll revise Caban's protocols in the next slide. More answers? Very good, Lily. Okay, very good. All of you have got this correct. RTHS SR. Caban's protocols is for TMJ ankylosis. So this was a very straightforward question which I had put in here. But the idea behind putting this question was to revise Caban's protocols. Alright, so Caban's protocols were originally given in 1990 and he modified his own protocols in 2009. Alright, so you can take a screenshot of this. These protocols are important. Very good, Nimisha. These protocols are important. You can take a screenshot of this. And you have to remember this. So the first point is aggressive excision of fibrous or bony ankylosis. What do you mean by aggressive excision? That means you have to completely remove the ankylotic mass. You don't have to leave behind anything which forms a part of the ankylotic mass. So aggressive excision of ankylotic mass. Okay. Coronoidectomy on the affected side. Coronoidectomy on the affected side so that you can achieve a good mouth opening. Alright, you can achieve a good mouth opening. Now, after doing these two steps, after doing 1 and 2, if you have achieved a interincisal mouth opening of 35 mm or more than 35 mm, then you can directly go to step 4. Okay. But even after doing step 1 and step 2, your maximal interincisal opening is less than 35, then you will do the opposite side coronoidectomy also. Okay, understood? Fine. Then the fourth step is lining of joint with temporalis fascia or native disc if it can be salvaged. That means if you can retrieve the native disc from the ankylotic mass, well and good, use that. If you cannot salvage or you cannot retrieve the patient's original disc, you have to give a temporalis fascia which lines the glenoid fossa and acts as a disc. Okay, maximum number of times the native disc is not salvageable. We have to line the glenoid fossa with glenoid fossa lining materials. Glenoid fossa lining materials I've taken in detail in my class. Okay, now the next step is reconstruction of ramus condyle unit with either distraction osteogenesis or costochondral graft. Okay, then you have to make sure that you have now altered the anatomy of the joint. You have removed the condyle, the ankylotic mass, so now you have to reconstruct it either by distraction or with costochondral grafting. Okay, followed by early mobilization of jaw. Alright, you have to get the patient back into mouth opening function as early as possible. So what does this say? If you are using distraction osteogenesis to reconstruct, mobilize on the day of surgery. If you are using a costochondral graft, mobilize it within 10 days. Alright, mobilize it initially with minimal intermaxillary fixation. Okay, but after 10 days you have to completely mobilize it. Why we wait for mobilization in costochondral graft? So that when we have placed the costochondral graft, we secure it with plates and screws. We let the initial healing take place, initial adhesion, initial healing take place, and then we mobilize the costochondral graft that you have placed to reconstruct the joint once it has gained some strength. Okay, followed by aggressive physiotherapy. This has to be done for a very prolonged period of time to prevent chances of re-ankylosis, because you have done a joint surgery, you have removed a part of the joint, there is osteogenic potential, there is organization of blood clot, and both of these things can give rise to ankylosis again. So you have to give aggressive physiotherapy so that you keep disrupting the clot. So last 2 points, early mobilization and aggressive physiotherapy, are to prevent re-ankylosis. Okay, so I hope Kaban's protocols are clear. Now coming to question number 7. For a 8-year-old with TMJ ankylosis, the treatment of choice is A. Gap arthroplasty, B. Condylectomy, C. Gap arthroplasty with costochondral grafting, and D. Treatment is not required. So what would be the answer here? Please answer. Yes, more answers. Very good, all of you. Okay, now let's discuss this question. I'll tell you the correct answer and then we'll discuss this question. So gap arthroplasty with costochondral grafting. Please note the question says 8-year-old patient. 8-year-old patient is a pediatric patient. Growth is ongoing, so we have to replace the growth center present in the condyle, because that you will be sacrificing during your arthroplasty. Alright, now I just want you to pay attention. Children or pediatric patients and adult patients. Okay, here in children you will do a arthroplasty, alright, which will be a gap arthroplasty. You will create a gap. Okay, you will give a glenoid fossa lining material. Okay, plus growth center transplantation. That means you will transplant a growth center over here so that the growth of the child is maintained. It is not hampered. Now, growth centers are costochondral grafting, metatarsal head, and sternoclavicular joint. Okay. So these costochondral grafting, metatarsal head, sternoclavicular joint, they have their own cartilaginous part which causes growth at the joint. Alright, so that is why you have to replace the growth center. Whereas in adults, you can do a arthroplasty, gap arthroplasty plus glenoid fossa lining material. So this becomes a interpositional arthroplasty. So in child, interpositional arthroplasty plus growth center, and in adult, just a interpositional arthroplasty. Is it clear? Aarti, have you understood? Please let me know. Question 8. Which of the following agents can be introduced into the joint cavity for therapeutic purposes? 1. Diclofenac, 2. Clindamycin, 3. Hydrocortisone acetate, 4. Metronidazole. So your options are A, 1, 2 and 3, B, 1 and 3, C, 1, 2, 3, 4 and D, 1 and 4. What would be the correct answer here? Very good. What is the correct answer here? Any more answers? Okay, so we will in the next slide see what all we can introduce in the joint. The correct answer is B. Okay, diclofenac we can give. We do not give any antibiotics within the joint. Okay, we can give a steroid. Okay, and again, like I just told you, we do not give any antibiotics into the joint. Okay, now I have this table. You can all take a screenshot of this. So the type of drugs that you can introduce in the joint after TMJ arthrocentesis. So whenever you are doing a TMJ arthrocentesis, first you will do a lavage of the joint or wash the joint with Ringer's lactate or normal saline. Ringer's lactate is preferred over normal saline. And for once you have given a lavage, once you have washed the joint, you can give some therapeutic agents depending on what the patient's condition is. So the therapeutic agents are as follows. Corticosteroids, the mechanism of action is anti-inflammatory by inhibiting the lipooxygenase pathway and it causes pain relief. Okay, the examples are hydrocortisone and dexamethasone. The next type of drugs that you can introduce in the joint are NSAIDs. These are also anti-inflammatory, but they inhibit the COX pathway and they also provide pain relief. The examples are diclofenac and piroxicam. Okay. Apart from these two, you can also introduce opioids. These are centrally acting analgesics and they also provide pain relief. So the examples are tramadol, morphine and fentanyl. Okay. And you can inject certain enzymatic preparations which are they improve the disc mobility by breaking down adhesion. So if the disc is, say, let's for example presume the disc is stuck to the clinoid fossa, so you can introduce these enzymatic preparations so they break down the adhesions and they improve the mobility of the disc. So the example is hyaluronidase. Okay, so this is an important table. Questions have been asked previously, so you can take a note of this. Okay, HS, SR, I hope you both have understood. Please let me know. Coming to question number 9, most common complications of condylar injury in children: A, pain; B, osteoarthritis; C, ankylosis; D, fracture of clinoid fossa. So what would be the correct answer here? Any more answers? So this is a very straightforward question. Okay, Aarti, you say A and C. So the answer is C. A is pain. Immediately as a part of the injury, as a sign and symptom of the injury, there would be pain. But it's not a complication. Complication is something which happens long term. So the correct answer here is ankylosis. Okay. And if a child has suffered a condylar injury, we make sure that the child is mobilized early. Okay. Is doing active physiotherapy or physical therapy so that the chances of ankylosis are prevented in the future. Okay. Coming to question number 10, perforated disc of TMJ is seen as a sequelae in which of the following conditions? A, TMJ ankylosis; B, anterior disc displacement with reduction; C, anterior disc displacement without reduction; and D, TMJ ankylosis. Any answers here? More answers? Okay, so I'll just explain this question. I'll tell you the correct answer. This is anterior disc displacement without reduction. We will just see a few clinical features about both. I have explained disc displacement with reduction and without reduction in detail in my classes. We won't go into much details, but just to understand this concept, we'll look at a few pointers. So in anterior disc displacement with reduction, there is pain on mouth opening. Okay, there is a click on opening and there is a click on closing. And after initial 10 mm of mouth opening, there is deviation to the affected side. Okay. Now, anterior disc displacement without reduction, the disc interferes with the condylar movement. There is trismus. there's trismus, and it can progress towards perforation of the disc. Okay, now how it can progress towards perforation of the disc, I'll just tell you. Okay, this is the glenoid fossa. And here in anterior disc displacement without reduction, what is happening is the disc is placed like this. It is anteriorly dislocated, it has dislocated, and it is stationary in this position. Okay, it is in an abnormal position. All right, it is in an abnormal relation to the condyle as well as to the glenoid fossa. It has displaced anteriorly and it is stuck in this position. Okay, now in disc, I'll very briefly tell you, we won't go into with reduction into disc displacement with reduction in detail, but what is happening in disc displacement with reduction, it is in an abnormal position, but there is some mobility of the disc which is present. Alright, that is why you get the clicking sound. But what is happening in disc displacement without reduction is a scenario like this. Now, this is the condyle. Okay, this is the condyle. Okay, this is the condyle in disc displacement without reduction. Now this disc here is stationary in this position. Now whenever, understand so you won't forget, now whenever mouth opening is happening, okay, the disc is interfering with mouth opening. The disc is stopping, or it is present in the path of the condyle. So when the mouth is opening, because disc is limiting the condylar movement, there is trismus. All right. When the condyle hits the disc repeatedly, it comes in contact with the disc repeatedly, there is pain. All right. Now, if a patient is trying to continuously force open the mouth wider against this disc, so what will happen? Continuous trauma to the disc will lead to perforation of the disc. It will tear. Okay, so I hope now you will not memorize this, but you have understood why there is risk of perforation of the disc in disc displacement without reduction. Is it understood to everyone that why is there trismus, pain and perforation, risk of perforation of disc in disc displacement without reduction? Let's come on to our next question, question number 10. Okay, this is question number 11, I'm sorry. A 5-year-old child reported with history of deviation of chin to left side and progressive decrease in mouth opening for past 2 years. Currently, the child has significant difficulty in mouth opening and feeding. Child's mother gives history of infection in front of ear on the same side 3 years back. What would be your diagnosis? So what would be the answer to question number 11? More answers? Any more answers? Okay, let's see the question. When you are given a clinical question, when you are given a clinical scenario, my advice and suggestion would be, please read the question word by word, have some patience, pick out what history is being given to you, try to record that history from the question. A 5-year-old child, 5-year-old child, deviation of chin to left side, progressive decrease in mouth opening for past 2 years. Okay, currently child has significant difficulty in mouth opening and feeding. Okay, child's mother gives history of infection in front of the ear on the same side, the side that we are talking about 3 years back. What is your diagnosis? So we all know, I have told you in my class also, most common cause of TMJ ankylosis in developing countries is middle ear infection or otitis media. Okay, apart from that, if you see, it is a child in question, there is deviation of mouth opening to the same side and progressive decrease in mouth opening. That means over a period of time, the mouth opening is keeping on reducing. Okay, and this history is present for the past 2 years. That means after the infection happened, the patient started developing these symptoms. Okay, and now he has significant difficulty in mouth opening and feeding. Okay, and there is a history of infection. So these are all clinical features of TMJ ankylosis. Along with the history, it correlates with the history of TMJ ankylosis. And there is deviation to the left side. That means this is a unilateral TMJ ankylosis, because in bilateral there won't be any asymmetry. In bilateral ankylosis there is no asymmetry that is seen. Asymmetry or deviation to the ipsilateral side, same side or affected side is seen in unilateral TMJ ankylosis. So the answer here is left TMJ ankylosis. Okay, the answer here is left TMJ ankylosis. Okay, fine. Have you understood, Aarti? Now, this is question number 12. And the last question for today's session. Identify the fracture in the given image. Very good, Aarti. Identify the fracture in the given image. A. Condylar head fracture. B. Condylar neck fracture. C. Fracture of glenoid fossa. Undisplaced condylar fracture. Okay, more answers. Very straightforward question. Okay, this is a condylar neck fracture. Okay. Now I have put this question to explain the difference between deviation, displacement and dislocation. In the last session someone had asked a doubt. So this is a small topic in itself and it will take 10-15 minutes. I have put this so that we can understand the difference for once and for all and you people are clear. So now when we are talking about deviation, displacement and dislocation, it is usually in relation to the TMJ, alright, or in relation to the condyle, and that to a fractured condyle. Okay. To understand these three terminologies and the difference between them, we need to look at the classification of condylar fractures, especially the one given by McLennan and Lindahal. Alright, so this classification has three components to it. The first one is based on anatomic site or location. Okay, now I'll draw a diagram. So that you all can understand. Okay, now this is a condylar head fracture. This is a neck fracture at the narrowest part. Okay, and this is a subcondylar fracture which involves the sigmoid notch. Okay, now please remember, whenever you face any difficulties in remembering a concept, please remember it diagrammatically. Now this is a intracapsular fracture, this one, the condylar head fracture, because the condylar head is involved in the TM joint. It is present within the capsule of the joint. That's why it becomes intracapsular. The neck part and the subcondylar region are present outside the joint. Although they are part of the condyle, but they are not the articulating surfaces of the joint. So these two become extracapsular. Right? So intracapsular and extracapsular. Okay, so based on anatomic site or location, we have a condylar head fracture, condylar neck fracture, or a subcondylar fracture where the sigmoid notch is also involved. Okay. Now coming to the next part, that is classification based on relationship of condylar fractured segment in relation to remaining ramus stump. So basically the relation of the condyle to the remaining ramus stump. Okay, so it says no displacement, it says deviated or angular, it says displaced, that is anterior overlap, posterior overlap, medial overlap or lateral overlap, and it says no contact when it is not at all in contact with the ramal stump. Now let's see what is displaced, because I have diagrams for other two. Okay. Okay, this portion where it is overlapping. So this can be a lateral overlap. Alright, if it is overlapping anteriorly, it will be an anterior overlap or anteriorly displaced fracture. If it is posterior, it will be posterior overlapping or a posteriorly displaced fracture. Okay, no contact will be like this. No contact will be like this. Alright, it is completely detached from the ramus stump. It is not in contact. Okay. Let us see here. No displacement. That means there is a fracture line, but anatomically the condyle and the ramal stump are associated with each other in a correct anatomic form, and there is no movement. So there's just a fracture line but no displacement. Deviation, there is a fracture line, but this has deviated at an angle. So deviation or angular. Okay. This is displacement. Alright. So if we imagine this fracture is extending like this, so anterior overlap, displacement. Okay. No contact, I have already shown you. Now classification based on relationship of condylar segment to glenoid fossa. So the first one was anatomic side, second was relation of condyle to ramus stump, and now it is the relation of condyle to the glenoid fossa. So here we have non-displaced, that is normal relation to the glenoid fossa. We have displaced in glenoid fossa, alright, and dislocated, that is condyle is outside the glenoid fossa. The no contact diagram that I drew. Okay. Now I will just draw no contact here again. Dislocated. Condyle is outside the glenoid fossa. It is not in the glenoid fossa. Let's see our diagram again. I'll use this green pen. So pink was for ramus, relation to ramus stump. Green is for glenoid fossa. So if you see here, this is not displaced. The condyle is lying in a normal relation to glenoid fossa. Alright, normal, so non-displaced. Here the condyle is in the confines of glenoid fossa, if you see carefully, but it is not in an abnormal relation. It is in an abnormal relation, but it is within the glenoid fossa. So this becomes displaced. This becomes, it is displaced in the glenoid fossa. Alright. Here also the condyle is within the glenoid fossa. If you see, the condyle is within the glenoid fossa, but it is present in an abnormal relation, or it is displaced in glenoid fossa. And dislocated, I have told you, dislocated, that means it is in a different location. Remember it like that. Dislocated, that means it is in a different location. That means it is lying outside the glenoid fossa. Okay. So this is a repetition of the same which I just told you, this particular diagram. So I hope things are now clear to you, the difference between deviation, displacement and dislocation. Alright. So with that, we will end our session. Just a reminder that from 1st of September, we are starting the INI PYQ Masterclass. So we'll be discussing previous year's questions of INI in a run-up to the INI CT MDS exam on 9th of November. With that, I leave you with the schedule for the next few days. Happy studying. Thank you for joining in, students.